Very warm welcome to all of you in second session of Paediatric Oncology. I am Dr. Ahila, working as senior instructor in Shaukat Khanum Hospital, Peshawar, and I have great pleasure to chair this session with my colleague Dr. Tahir. In this session, we look forward some most informative and insightful talks from for a very most common intraocular malignancy, which is about 95% curable in resource-rich countries with saving of vision in most cases, but still a challenge in our middle and lower income countries like ours. Now, let's start. Our first speaker is Dr. Guillermo Chantada. He is the head of outreach program of pediatric cancer Barcelona at the hospital St. John de Dieu and in hospital Argentina. He's also the president of International Society of Paediatric Oncology. Retinoblastoma is his special interest of research. He had to present virtually, but unfortunately, because of an accident, we will enjoy his talk, his recorded talk. It is about locally advanced and relapsed refractory retinoblastoma in resource-limited countries.
The decision tree that I showed. Okay, this is the answer. Sometimes, if the child is very young, they're 2 or 3 months old, we can suspect that there is probably an retinoblastoma behind. Some patients present with chronic retinoblastoma, so we have unilateral representation and then after so I'm talking about the children 2 or 3 years old that come with unilateral disease. The tumor is not available. It is not present in the clinic. There is no family history. So these children, ideally, if we have the information that they don't have germline complication, these children are not an increased risk of secondary malignancy. They have no increased risk of trilateral retinoblastoma. They will have no visual advantage compared to the creation PI research. So we are not fighting the vision. We are probably fighting just for the space. The vision is not going to be different because the other eye is going to be normal. So the results, the conservation results, the ocular restoration results are going to be influenced by the ocular. So, who are the patients? The unilateral retinoblastoma presentation. At that presentation, that we are going to think of observation. Definitely, those patients with D or C because the probability of anything in the eye and some vision are high, especially if the macula is involved, we can treat these children also with conservative treatment. Some patients with D, here I would say only there is intraocular therapy available, at least most of the time. Most patients with good D disease, with unilateral good disease, do not do well with systemic therapy. The results are very bad. And again, you are not finding the vision here. You don't even find the vision, fighting for the next. So, unless there is a strong position by the family about most looking eyes are do very well. So, in settings like many cities in Pakistan, other countries in Asia, in some countries in Africa, refusal of education is a big. So it is important that we don't confuse the children that we treat that with good eyes, for example, good eyes, that we have to give systemic therapy or intraocular therapy because the family does not accept an education. This is not conservative treatment. This is what we would do. But the treatment for those patients is radiation. So whenever it's possible, whenever we convince the family, the radiation of those for those patients, I think it's perfect. And then, okay, we are going to try conservative treatment in these patients with the which is the modality that we are going to decide. If we have intrathecal chemotherapy, there's no doubt. There is this retrospective study that I'm showing here done in Switzerland, and they showed that intrathecal chemotherapy is much more effective in very effective cancer, and also it has faster. Less. There was for many years not of coming up now we have 2 years now in chemotherapy targeting cell type within and the combination of therapy plus intravenous is combined now growing by 100%. These are local they are fighting for remission. And so we assume that these patients have no risk of metastasis. There are some innovative therapies, like the virus that we have in Barcelona, that we do non-chemotherapy. And now, years ago, here in Los Angeles, that therapy also carries intracameral therapy and many other groups intracameral therapy for treating irritation and number. So which are the advantages of IRA? First, they have proven by random study better results for registration. It's lower official, which is not so, there are small children, it's not so important, but it's important. Usually, all you can see is some eye drop. I mean, some children that have the prominent collateral, actually, they can have some alopecia in the frontal area. Much lower impact on the body, in low cases, or very few cases. No capital infection. Really much better tolerated now proven in the clinical study, even in COVID. So, and probably they have a less and lower impact. I say probably because we are using it for less, maybe 15 years now, or 20 years. And we have to wait until 2 or 3 more decades to see if the concentrations of the drugs that are probably higher in the CNS after chemotherapy could increase the risk of Japanese data, which were the pioneers in therapy decades ago. They are not seeing that. So it's probably that we are not going to see many symptoms therapy pandemic. Which are the disadvantages of IRA using more ocular side effects? Of course, you're giving higher doses of chemotherapy, you are to the eye, so you are going to see more toxicity, like any other organ that is chemotherapy. And you need a highly qualified. There is a big learning curve. You start intrathecal therapy. There's some piece of treatment that cannot be done anywhere. It has to be done in a place where we have a full intervention of the government. And most importantly, many cases, because there is going to be a learning curve. You treat 2 cases a year, you're not going to you're never going to the center, the turnover, the many patients, the experience and your participation. I talk a lot about it. I have given that to available with AIs and all the good AIs. In my opinion, in a lot of European settings are still treated by the why? Because I say procedure, as I always say, you can diagnose Monday, you will look at the child on Tuesday, and the child has a fever. And the follow-up is very simple. The functional condition of that child is but be sure using your best. Don't send your first year fellow to the application all the time. Say that I say safely when you take the dog particular stuff, and that also it's not a single surgical. Taking very seriously. Talk with the parents. If you want to say it's very to spend time. Ophthalmologist, ophthalmologist, urologist, and also about your resources. Yes, it's important to be flexible because sometimes I'm saying it's not that we don't have an operating room available in the next couple of days, or in the next week. When it has to be okay. But sometimes we can, sometimes we don't have the possibility. In those cases, that will be flexible. Sometimes we have to eliminate the therapy. Sometimes they can't eliminate therapy to buy time. Make to digest the decision of it. It is the recommendation is not the recommendation is behind the practice. But that is because family access and they have available an operation for the next day. Some local practice don't have to wait 1 month because we are going to use the phenomenon. Have to say the child is like first. And we need a post therapy, and that's the reality that many times. And it's also important when if the diagnosis here, the chances of having a good extraordinary disease are very low. You can still try to do this service. Again, it is unilateral. I will still favor the diagnosis. In a DI, unilateral case, you're I will still favor it. Because you can't, you try, you can still be successful in this without putting the patient at risk of metastasis. But whenever you advance and you get here, you are really facing a lot of risk systemic disease. But when do you go from the second to the third row, the third red column, that is really challenging. So whenever you are there, the risk of extraordinary discrimination can go very fast, from minimal to 10-20%. So then you are not, it is unsafe trying to say those sides. That to go to the location of completely sure that you need a location. And what is the situation in bilateral or in hereditary? We either really took about 2 years to reach consent. In Latin America, the groups in Latin America, supported by our group also in Barcelona, made a consensus, including Barcelona and Portugal, on how we approach the So here, the situation is here, as I said, depends on cooking, and also you have two eyes. Right? So most of the times, patients will arrive with one eye giving cooking, and the other eye giving. That is most of the times even in the income. Those cases can be managed by different modalities. One modality can be to eliminate and die and then treat with systemic chemotherapy. They're going to get good results. They are probably going to save 80%. And here I think to concentrate on the items. You start with the part of the from this idea. You will try that's that is sometimes there will be items you can say otherwise never know. Never know if they're going to have very good everything that after and then you only the issue of the product. You can get a chance. But most of the time, I can still recommend the plus systemic therapy of the good eye. Even if you suppose you're lucky and you are in the left part of the study, when both eyes are less advanced, and with A to C in both eyes, most of these cases are ones that have very history. These cases can be managed with systemic chemotherapy. The response is beautiful. If you have intravenous chemotherapy, the second quarter eventually during relapse, you have a relapse, and then you can this product. Why I say that is because, as I said before, the optimal consistency of intravenous chemotherapy is higher. So if you have an high population and you're giving a treatment that can cause permanently, I would give it for the second line, except there is macular involvement. If a macular involvement is paralyzed, intravenous chemotherapy is different. But in many countries, the students are like this. If you have plus because much better. If we don't, well, we can try the systemic chemotherapy. The results are not very good, but anything you can achieve is okay. Otherwise, you will be able to pass. But you cannot use the orbital popular surgery. If you get to that point, the problem play in the state probably Zambia or various cities where you can try a couple of cycles of chemotherapy, secondary, and then treat. Each eye is interfered therapy, collaborate, plus later that if you systemic chemotherapy with the eye, always will try to keep it low, even tries to metastatic. What do you do if you don't have You can try it. You can save one of these eyes without. You can use systemic reduction plus intravitreal therapy for no longer the substance. There's limited access to some you have another availability of once you make the learning, probably you can use it for perhaps this size risk you can adapt it. But first, with the learning for KPIs that are obvious. Because this size you are going to have toxicity, so it's good that you have this toxicity in the eyes that you are going to use immediately the learning program. I like very much this concept that was in the interviews about the state of the space. You are in the retinal treatment, you are probably going to, this slide is going to be how many times did you place it place when we diagnose start when you go to some days to try studying for a couple of months, then another relapse, then a couple of more into a year, it's the drug. Then you put a plan, then you put some drug, then 2 months later, another relapse, then you go steady with other days, then you go to very often, people days. Sometimes we don't know when. Unfortunately, we have to probably the features, the different diets will help us with that. And the different diets will testing when this state of the is lost. And then the child is a risk or second of the component that is your next. Sometimes we published a paper in the European book a couple of years ago about the indication of secondary. Sometimes we have to do and we have to test that. A couple of words of new treatments that we have in Barcelona is a virus, an oncolytic virus that is targeting the RB1 pathway. So only activates when there is dysfunctional RB1 pathway and into a pathway that server, with this pathway is dysfunctional, you need to have split with the tumor and the virus and we are still in phase 1. I hope this how couple of conclusions to the end. How popular decisions will be made knowing the local situation. Don't economic understand. Don't do exactly what is being done in Paediatric. Adapt to your reality. This is the best way and learn from the data, analyze. If there is in cases where food dissemination is unlikely, indoor chemotherapy plus indoor is better response. As fast as faster and is less cost. Proven by others. Patient selection is critical. Again, that was much of my fun. I'd like to thank you very much for your attention. I hope I can answer your questions. Thank you very much.
She has been working as a second for last 10 years. She has participated in but it's very data for us and now he will update us next.
मैंने अपने आप में वो किया था no idea no I can both this is इसमें आपके पास आया है पेपर सेशन 2 उसमें वो ना डाल दिया yeah should we do the panel okay and I will find
Now we will continue our session by dynamic panel discussion. I have the pleasure to introduce our panelists. Our first panelist is Professor Shaukat. He is the head of department of Paediatric Oncology at Al-Shifa Eye. She has more than 15 years of experience in pediatric ophthalmology. Her area and start technology of the maturity, pediatric glaucoma, chapters of the trauma and sedation and retinal. Our second panelist is Dr. Hussain Ahmed Khanum, who is an ophthalmologist at Khanum Hospital, Lahore. He has generally years from UK and CPS in vitro from Pakistan. Our third panelist is Professor Dr. Shaukat, who has more than 20 years experience at Paediatric Hospital. Our last panelist is Professor Khanum, who I have the honor to work with him and my mentor. He is a pediatric oncologist and currently commandant of armed forces.
And from the knowledge And we were able to select both sides. And this is the side that is the side. Treatment in our center. They everyone thoroughly exhausted about the need for treatment. And it was done at 2 months of age that was negative. And the parents were told by the local authorities that the child is fine and there is no need of further evaluation. Then as the age moved 8 months, when our mother noticed physical distress in his eyes, and then they went to ophthalmology. And the referred them to the India was done as the baseline system and it right eye was bleeding and was seen in the left eye. And now had multiple biological are that depends on the class and one thing and the baby data and because of that, was negative, but also given 10 to 1. So the child was the reason for it, and then we are going to try after the time to go, but all the things go. So we are going to is as well the rest of the and federal for here, the first thing that we have done was the first examination of them and 2 months of it was humanitarian. But I can understand that there is some that hospital even after going to registry of data figures to the it was good that the child was well at 2 months. But again, we failed our system or whatever. The child had protein because it was not seen for 6 months. Being a very high risk case, the child should have had e-waves every month. So this is the protocol for high risk cases. At birth, for the first 2 months, we should screen every 2 weeks or 4 weeks weekly, and then after 2 months, every month for the first year. And also some centers, they say that it should be that we should continue examining every month for 2 years, but that can be quite a burden for the family and the clinicians. And if the child is going well for the first year, maybe can increase the gap to two monthly for the second year of follow-up. But yes, for the first year, it is every month examinations or EUAs. And it has to be an EUA, examination under anesthesia, which is the preferred screening exam. Because an office exam for a very small child, unless and until you're a very much trained ophthalmologist, can do the scleral indentation in your office, see the aura, see the whole part of the retina, only and only then you can do an office exam for in the first 2 months of examination of the after birth. Otherwise, the recommended is that you go for an examination under anesthesia. And after that, after the first and 2 years, then every 3 months follow-up for the till the age of 5 to 7 years. And that's the recommendation for this child. And lesser frequent EUAs, 3 monthly and 6 monthly intervals for all children, the intermediate and low risk capacity, then they can be followed up 6 months after with 6 monthly intervals. But then again, the point here that I want to make is that we enucleate the advanced diseased eye, and then we don't counsel the parents well. I feel this is what is lacking on our part. That is what we can do. If they don't comply and they don't come to the hospitals on time, that's another issue. But I've seen cases being referred because the parents did not know, that they were not counseled, that they were supposed to come back for screening. And एक आंख में group E था, group D था, and that was enucleated, and the patient was sent home, and the doctor साहब ने कहा था कि बीमारी खत्म हो गई. So simple enucleations and then sending the child home is very much the practice in our peripheries, unfortunately, and it should stop.
Thank you,
Thank
Dr.
you.
Mehra, for beautifully explaining the screening process. Just for a reminder, this patient fell into high risk category because his parents had bilateral retinoblastoma, and low risk are sibling with unilateral. All of other fall in intermediate risk. Now, my second question is for Dr. Tariq. Sir, what is your opinion regarding CNS metastasis in low-risk intraocular disease like this in this child? And what should we think other differential diagnosis, and what is the role of MDT in such cases?
Thank you very much. We basically in the localized disease, CNS involvement is quite rare, and definitely the MDT has a role because we have maybe 2 or 3 patients, and they are very difficult to cure as well. We went for the second line chemotherapy followed by radiotherapy, and one of my patient out of the 2, he could not be cured. But definitely MDT is a way
Definitely.
forward for this discussion.
Had this patient not been discussed in MDT, the report said metastatic disease. Thank you. Now we will move to our next case. It is about a 2.5 years old girl. Her sister noticed white eye reflex 8 months before, and parents just ignored. And then when it increased and became more obvious, then they sought medical help. B scan was done by local ophthalmologist, which was suggestive of retinoblastoma. Then they did the MRI scan, and it showed intraocular disease without optic nerve involvement. So the parents were advised enucleation, which they refused and came to the hospital. When we did the workup, the left eye showed a group D disease, right eye was normal, and bone marrow CSF was negative. But the MRI scan, which was negative for optic nerve involvement at the periphery, there is some problem in the selection and transfer of hope. It showed optic nerve involvement on MRI. So the final diagnosis was extraocular retinoblastoma. And after discussion in MDT, the CEV chemotherapy of 10 cycles were planned, and reevaluation after 2 cycles followed by enucleation and then radiotherapy. Currently, this patient has received 2 cycles of chemotherapy, and he is undergoing reevaluation. So this is the question. What if MRI image I think would transfer of file from the in USB would lost हो गई या बीच में से गई. So, sir, what if the child has tumor with optic nerve involvement? So, what is the preferable option in upfront versus delayed enucleation? If the ophthalmologist is confident that he can remove the involved optic nerve.
What we normally see is the patient, you sometimes go to the ophthalmologist first, and they usually give 2 courses of chemotherapy, and then they followed by the enucleation. Because probably I mean, you can try the enucleation with the clear-cut margin of the optic nerve, but probably ophthalmologists are more comfortable after the 2 courses of chemotherapy, and that increase the chances of cure. But definitely these children will require the radiotherapy after chemotherapy.
We have in our hospital our own protocol of giving neoadjuvant chemotherapy and then trying enucleation. And if we succeed in obtaining negative margins, negative optic nerve margins, then can we omit radiation in these cases after upfront enucleation?
I mean, I think this is again debatable, because what I have seen, sometimes the patient they relapse. So if you ask my own personal opinion, I would still recommend radiotherapy.
Thank you.
Thank you. I would like to add here that it has to be case according to the cases. Whether to give radiotherapy is always a big decision. But I feel that if the optic nerve involvement is there, and depending upon the length of the optic nerve involvement seen on the MRI versus the length resected, and even if you have a free margin, but the distance of the involved optic nerve from the free margin is less, then I would advise going for radiotherapy, especially if the optic nerve involvement is more than 3 to 4 millimeters. It's considering it becoming an orbital disease. Then because of occult disease might be present in the stump that you're leaving behind, might have been missed on histopath, might have been underdiagnosed because of the previous chemo that you have given, then I would advise going for radiotherapy in those cases. But if there is a post-laminar optic nerve involvement with a good about 10 millimeters or more of clear nerve, you feel that probably the risk of occult disease in the orbit is less, then we can just observe and follow the child more frequently with MRIs and more early MRI post-enucleation. Thank you.
Thank you, Dr. Mera. Dr. Khakan has joined us online, and he has some opinion.
Yes.
Please, Dr. Khakan.
Hello, can you hear me?
Yes.
Okay. So good morning from Lahore, and I apologize for not being with you in Peshawar. I have a quick 2 comments. I will not take much time regarding the first and second case. Regarding the first case, you mentioned about EUAs, and I would like to stress that there is no way of examining a retinoblastoma child without EUA. Examining a child, whatever the age it is, 1 year, 2 year, up to 5 year even, it is impossible to do the indirect ophthalmoscopy with indentation in a child. And it's not the way of examining a child who is suspected for retinoblastoma and who is currently going for the treatment or for follow-up retinoblastoma. So it should be done under anesthesia, and it should be done properly as we do with the indentation. There's no way of examining the child without anesthesia, and there's no logic. You cannot, even I bet a best retinal surgeon, best ocular pediatric oncologist, even ophthalmologist cannot examine a child without anesthesia. So it's my 1 point. Second, regarding the second case, the MRI. MRI is very important. MRI is not only important to know about the involvement of optic nerve or an extension of optic nerve and involvement in the brain. You know, most of the cases in the group D and group E, they present with the exophytic lesions, and sometimes their retina is detached up to the anterior highlight, and there is also vitreous hemorrhage. On examination under anesthesia with indirect thermoscopy, you cannot even see the tumor size. And it's impossible sometimes to give the grouping of that eye. I mean, it looks like group D or E, but you never know the size of tumor. Sometimes the tumor size is very small, but it gives a massive exudative retinal detachment. So it's sometimes very difficult to group the patient according to the lesion size and according to the involvement inside the globe. So MRI helps also in these situations also for the grouping and further management. My last point is regarding the optic nerve involvement and how to proceed. In my practice from last 15 or plus years, I prefer to start the chemotherapy and get a good negative optic nerve and end up with the full chemotherapy and with the radiation, because the clearance of optic nerve and doesn't guarantee you that disease is not progressing. So, okay, let's just keep in mind. If it is with the chemo, it's for sure. If it is without chemo, a clear end, it even doesn't guarantee you that disease has been cured. So you should proceed with the chemo and radio. This is almost all from my end, and I would like to hear the comments and further discussions regarding this end. Thank you.
Thank you, Dr. Khakan.
I would like to second Dr. Hossain Khakan. The disease we see in this part of the world is even worse. At least 10% of patients present with proptosis. And the more than 500 cases that I've been involved in treatment over the last 20 years, I would say advanced eye disease that I've seen is in unilateral is approximately 90%, and in bilateral it will be 60%. So as Khakan said, we can't trust these eyes with the genetic pool, with the bilateral disease. You are enucleating, you can't be sure if you have left any microscopic lesion, tumor inside the residual stump. So my practice has been always to start with chemo and then go for enucleation. And it gives time to the patients. If you first tell them in the first go that we are going to remove the eye, parents can't take this trauma. So if you are giving them chemo, they're giving them time, and you also saving the child as well. Thank you.
Thank you, Dr. Zafar. Ji, Dr. Zaya.
I can't. Okay, thank you. Thank you for the interesting cases. I'm Dr. Zahra from Khan University. So again, the comments that Dr. Khakan said, fully agree with that. One thing is important, that MRI that is done at the outset, you have to also understand it's not only the optic nerve that you're looking at, you're also looking at the ocular outside the globe. So post-laminar, pre-laminar involvement, scleral involvement, because these are our high-risk features, okay? So not only optic nerve, but scleral involvement, the extent of scleral involvement, the touching of the lens, what else are. So everything around the globe has to be reviewed in that MRI. And I think that's where your MDT comes in very important. Any child that is upfront has a high-risk disease should have an MRI and be discussed at an MDT, so that the ophthalmologist, the pediatric oncologist, radiation oncologist are all on the board with the same management. And whatever stage that was done at the outset, that means the first time that you saw the child and you decided this is group E or it's an extraocular disease, the treatment has to be at that the decision of the treatment has to be at that stage. So your decision doesn't go back and you do not restage it or understage it after your enucleation. So that is, I think, the point that Dr. Khakan was also saying, that whatever these eyes that you did, through MRI, you classified them as extraocular disease, should be treated accordingly and not downstage later on. And that actually the pressure comes from a parents a lot of time, because if you start the chemo and then you do the MRI after that, and then things are much better, and so they say कि नहीं आप ना निकालें या आप try कर लें all. So that I think we all have to be very sure, and everybody has to say the same thing. Said this was the decision at outset, and it will continue because this is the best. Life comes before your anything else. So thank you.
Thank you, Dr. Zara. So this is a consensus in our panel that better is new adjuvant chemotherapy and then try enucleation. And secondly, as Dr. Zara said, the initial staging. Let's see the question. Okay. There are
It was the original one.
There are two questions from the Zoom chat. Okay, first question is regarding the treatment option for children with advanced group D disease, where we don't have availability of intra-arterial chemo procedure, and the response to systemic chemo is inadequate in terms of disease control, and parents are not willing for enucleation of eye.
Yes, this is a common scenario we see in the practice. Of course, a lot of parents, they do not agree to enucleation. So that's what I'm saying is when you start with chemo, at least you can every time that they come, you can try to convince them that this eye has to be taken out, and you have to, it's not like in the Western countries where the state has the responsibility. Here, the state does not have the responsibility. It's the parents who have the responsibility. So you can't force them to enucleate the eye.
Thank you, Dr. Zafar. Uzma, you must have. There is a second question from Sana Gill. Do you think FTG, PET or MRI in future could potentially serve as alternative to EUA? PET or MRI as an alternative to EUA?
No, EUAs and live examinations do not have an alternative. And very small flat lesions, जो perhaps जो सिर्फ discoloration होती हैं to begin with, they are missed on MRI, and it is not at all an option.
Thank you, Dr. Dr. Khakan.
Yes, I just can you hear me? I just want to add this one that MRI will never replace the ocular examination with indirect ophthalmoscopy. Will never, because MRI just gives you a one-dimensional image that doesn't let you know the severity of disease, the vascular element in that lesion, and the pattern of that lesion. So that cannot be achieved with any imaging till the day. So see the vascular pattern, the progression of vascular pattern and progression of the lesion. That cannot be measured or cannot be quantified with the MRI. And so MRI would never be going to replace the examination under anesthesia. There was a very good point mentioned by Professor Zafar Iqbal. Hello, Zafar. How are you doing? So I miss your company over there. So this is very important regarding the starting the chemotherapy in group D disease. Believe me, I will just take 30 seconds more. I will not take much time. I had a patient in the age of 3 months, and she had the bilateral retinoblastoma, and the parents at that time refused the enucleation of E disease and D disease in both eyes. And they said rather the daughter should die without having the eyes. You can understand. But we started the treatment her, and we survived the both eyes. And now she is 4.5 years. And unfortunately, now we had again the recurrence. But now the parents are so much educated, so much convinced, and so have been through process. His father himself is saying that yes, the bad eye you can remove because other eye is almost 100% cured. So you can. So I just want to take these points. So try to understand the trauma that we are just exposing to the patient by saying that your kids need enucleation in next week. So rather than doing this, linger on this situation with the treatment and make their life more comfortable. That's the only a empathetic point that we can add in our practice, and it would help in many ways.
Thank you, Dr. Khan. Any other?
I would like to add that the EUAs that we do is in fact because of the detailed view that we get of the tumor, whether it's progressing or regressing, that also advises the oncologist to continue with the chemotherapy or move on to a second line or not. So this is really the EUA examinations under anesthesia to view the details and also to provide the local treatment if required. Because आप EUAs के दौरान ही देखते हैं कि if there is some activity, then you lase the tumor, or you can go for cryotherapy, or can give intravitreal or sub-T non-periocular injections, whatever the need be. And also, if the tumor is doing well or partially regressed and you want a more effective chemo cycle, which is due after a few days, then you can go for a pre-chemo cryo application to the eye, which will what it does is it breaks the blood retinal barrier and provides a better absorption of the drug into the eye, and effects on the tumor are enhanced.
Thank you, Dr. Smera. Now we have another interesting case.
I have a question.
Okay.
Thank
Please.
you. I'm Dr. Nazri. I'm a pediatric ophthalmologist at KTH Peshawar. My question is, I mean, whenever we encounter a patient with bilateral retinoblastoma, we treat it as a hereditary case. But in case of unilateral retinoblastoma, that has been treated whether conservatively or enucleation has been done. So how frequently should that child be followed? Because we don't have the facility of genetic testing. And if in case of enucleation, the resected margin is free of tumor, how frequently that child should be followed? Because I remember one of my patients that has been enucleated, and he's coming every year repeatedly for examination, because they are consulting and they are going to Shaukat, Khanum, Lahore every year for change of the prosthetic eye, and they change the prosthetic eye only when they have the report of EUA. So how frequently and till what age UV should be done in case of unilateral retinoblastoma, either treated conservatively or with enucleation?
Thank you, Dr. Nazi. Ideally, genetic testing should be done for bilateral cases and also for multifocal unilateral cases with multifocality lesions agar multifocal hai, or plus if it is unilateral with family history. So unilateral with family history or unilateral multifocal disease. So these might have a hereditary element to it. So genetic testing is warranted here, but like you said, hamare yahan nahi hota, and we are left with the excess burden of screening through EUAs, and we don't have an option. We have to go through it. There was a study done in India where they compared the cost of genetic testing versus the EUAs that the child has to go through, and they found that going for genetic testing in the long run is much cheaper, because once you are declared RB1 mutation negative, then आप उन members को at least you can forego, or you can see them much later. So here जिसने आपने कहा अगर उसकी multifocality थी या वो unilateral disease थी and there was no family history, then we generally advise a 6-monthly EUA for the first 3 years of life, and later on annually for next till the age of 7 years at least. 7 to 8 years, yes. And you need to do that, and after 8 years you can have an office exam. But still, it's a lifelong follow. Yes.
Depends on the child. Sometimes you will need EUA even after 7 years of age.
I'm talking about the recommendations, but obviously, case to case, very good.
Okay, any other? Okay, we will move to next. Ji, Dr. Khan. Nothing.
So, can I add one thing regarding, I am still stuck on the MRI. So examination under anesthesia is importance is that even when you are doing the MRI, no MRI or B scan cannot pick the vitreous seeds. So vitreous seedings is one of the earliest signs of recurrence. So that's I wanted to highlight why the examination under anesthesia is more important and it's compulsory rather than only depending on the MRI, because vitreous seeds cannot be picked on MRI in early phases. So it is must for examination under anesthesia. Regarding the question from Dr. Nazli, yes, unilateral disease, if you have a clear margin, you have upfront enucleation, yes, you are much secure, but it depends on what age. I've been through from Brazil to Portugal to Argentina from every consultant. So it depends much on the age. So if the child is about 3 or 4 years, he had got unilateral disease in 3 months before, and he's at group D or E, and you did the upfront nucleation, there are less chances of recurrence, or there are less chances of disease in other eye. But a child with the age of 5 or 6 months or even 8 months having a unilateral disease, he must have high risk of having the disease in other eye in later part of his age of 1 year and 2 years. I have a couple of cases where I found the disease before the 6 months of age, and their other eye was normal, but after the 2 years, they got the tumor in the other eye. So it is very important to follow whatever the cost it is, but it is not more than a life of a child or vision or globe of a human being. So EUA just takes 5 minutes or 3 minutes in experts, and obviously it costs much, but it's not costlier than the eye and life of a human being.
Thank you, Dr. Khan. We are really short of time, so we will drop third case and we'll proceed to Dr. Halima's talk. Thank you.
Okay. All right. Sorry about the mix-up, but now, yeah, you guys can stay. Actually, I would like discussion on the protocol as well, but I'll be really, really quick because I know I'm keeping people away from coffee now. So, let's go further. Okay. All right. So I'm Halima. I'm a pediatric oncologist at Shaukat Khanum Hospital. And I've been very involved with retinoblastoma in Pakistan since I've been here the last 10 years. And as a result of a lot of collaboration that we've done with our ophthalmology colleagues and the Pakistan Society of Paediatric Oncology, we have started a national protocol for a standard of care protocol for treatment of unilateral RB. And the objective of today's talk is really to very briefly talk about the protocol. It's not going to go over each and every aspect, but just to give an introduction of what it's about and just an update on what we have so far. And so I will, and as I was looking through, listening to Dr. Chandada's talk, I'm happy that we've actually adopted a lot of what he was talking about in lower middle income countries, other than the intraarterial, which we don't have available. So our team is huge because, it takes a village to raise a child, and I think it takes a country to treat retinoblastoma. You need all subspecialties. So we had ophthalmologists on board, obviously, radiologists, pathologists, biostatisticians, and everyone, and, oncologists, obviously. And we all got together, had many meetings, and finally came up with the standard of care protocol. So if you guys have cell phones that can scan this, you can get the entire protocol in PDF version from this. So please go ahead and do that. It is a research protocol in the sense that we're collecting data, and we would like everyone to be enrolled on it because so that we get outcome from this. But it is standard of care that a panel of experts has come up with. So even if you are not enrolling in your institution, you can use this as a guide. It has detailed guidelines about radiology, pathology, staging, and so forth, and it can be a good resource document. So, if you're not able to get it, I can share it later as well, but everyone can download the protocol from here. So I will skip the background because we all know what retinoblastoma is. Basically, the aim of the study was to diagnose and treat children with unilateral RB according to a standardized protocol at all institutions across Pakistan, resulting in greater accuracy in diagnosis and improving survival. That's why we started this. And the primary objective is to collect national level data for unilateral RB. So the study is on unilateral RB, but we are actually collecting data on bilateral as well. We don't have treatment guidelines for bilateral because, as we talked about earlier, those are individualized, but we are still collecting data to see how they are being treated, and then to determine the overall survival, event-free survival of children that are treated on the standardized protocol. So one of the main focuses of the protocol is to standardize staging. So if you have managed to download it, or you can get it later, it has detailed guidelines on intraocular as well as extraocular staging of RB, and it requires an examination and an anesthesia, a B scan, an intraocular pressure measurement, MRI orbit and brain, and a bone marrow and CSF in case of patients with advanced disease. So only if the patient has group E disease or extraocular disease do you need to do the bone marrow and CSF. The treatment schema is that every new patient of RB should have a EUA and a B scan. And again, in terms of the treatment stratification, they'll be excluded if they're bilateral, but the data entry will continue. And then an MRI is done for all intraocular stages except group A, which are at very low risk for disseminated disease. And again, bone marrow and CSF in cases of group E disease or extraocular disease. And then based on the results of these, you will either go to the intraocular protocol or the extraocular. So in case of the intraocular treatment protocol, we chose the International Intraocular Retinoblastoma classification. I know, previously Reese-Elsworth was very commonly used in Pakistan. A lot of our older patients are staged on that. We still get EUAs that are staged on RE staging, but that was at a time where radiation was being used. And what that showed you was your salvageability with radiation. The advantage of using the international IIRC is that it is predictive of effectiveness of chemotherapy in eye salvage. I will not go through the details of staging, mostly because there's no time, and I think all the ophthalmologists are familiar with it. But what's important is that once we have this accurate staging, it gives us our chances of salvage of that eye. So for example, if you have group A, there's a 100% chance that you'll salvage with just focal therapy. If you have B or C, there's a 90 to 93% chance that you'll be able to salvage that eye with a combination of focal and chemotherapy, and these patients should definitely be salvaged. In terms of group D and E, and I think Dr. Chandada also talked about it quite a bit, really with conventional chemotherapy, the chances of long-term salvage are very low and the risk of METs and disseminated disease is high. So in the absence of intraarterial chemotherapy, the recommendation on our protocol is to enucleate these eyes, unless of course we need to give chemo to sort of convince the family and so forth. So this is a busy flowchart going through the treatment regimen for your intraocular RB. I'll divide it into two parts. The first part really deals with the salvageable eyes. So for the group A eyes, you will just do focal therapy. For group B and C, you'll start with chemotherapy, do 2 cycles, and reassess with another examination and anesthesia. And at that time, make a decision about whether eye salvage is possible or not. We hope that for most of these, eye salvage will be possible, and they will go on to complete another 4 cycles of chemotherapy along with focal therapy. And so all of them will get 6 cycles of chemotherapy. So this is for group A, B, and C. Group D eyes will sometimes enter this from here if the parents refuse enucleation. So we will give them 2 cycles to buy time to convince them. Again, like Dr. Zahra mentioned and several people talked about, and it's kind of interesting that the panel discussion ended up happening first. So we've already talked about it, that this is just to buy time to convince the family. It is not because we think that we'll actually salvage this eye. So most of them should get their enucleation after the 2 cycles where you've had maximum effect in shrinking the tumor. If it was, near the optic nerve, it should have moved away, and you should be able to do a safe enucleation so that then you have your 4 cycles to consolidate with after the procedure. So these should ideally, by this time, we need to work hard on getting them seen by psychologists, bringing them into clinic repeatedly to counsel them, having them meet survivors with prostheses, good prostheses in place, so they are ready for enucleation at the end of those 2 cycles, and that should be clear from the beginning. And then the other group is those that agree to the enucleation, that are group D and E. And those, the treatment is based on histopathology. This, we again had pathologists on our groups, and there is there are many different criteria for defining intermediate and high risk. After a lot of discussion and review of literature, we basically have decided that if the cut end of the optic nerve is positive, is involved, or you have a skip lesion, which would have been our third case, it will be considered high risk, and they will receive radiation as well as chemotherapy, and radiation should be given after 2 cycles of chemo. If they have massive choroidal invasion, which again is defined in detail in the protocol, or if they have retrolamellar invasion. So if it's laminar, it's in front of the lamina propria, not in that case, but if it's retrolamellar, it will be considered intermediate risk, and they will get 4 cycles of chemotherapy and no radiation, and everyone else will just be kept on follow-up. So that was intraocular protocol. For the extraocular tumors, this is what we end up seeing quite a bit of. And these are just, they need to be treated very, very aggressively. Again, there was a lot of discussion about the exact definition of extraocular. So overt extraocular disease, like I showed in those 2 pictures, doesn't matter what the EUA shows, doesn't matter what the MRI shows, those are extraocular. So that's just on examination. Preauricular lymph node involvement, convincing preauricular. So a lot of times you have infected eyes and a small preauricular node, you can do an FNA, but you need to be sure that it's involved if you have any doubt. If it's obviously grossly involved, it's involved. Extraocular extension on MRI, we again have already discussed the importance of MRI in that, especially in terms of transscleral invasion on the MRI, which a CT will not show you unless it's totally gross. And again, optic nerve thickening, which is considered extraocular. And again, you may have an eye that was initially considered intraocular. It may have had an enucleation outside, or the MRI did not pick it up. But when you got the histopathology, there was transscleral invasion clearly seen on histopath. That is also defined as extraocular and not treated on the intraocular protocol. So those are the ones that sometimes get missed. Like, they have an upfront enucleation, so we don't think that they're extraocular, but they may be. The protocol for this, again, I won't go into the details of why we chose this, because there were several different protocols to choose from, but this is an outpatient but intensive chemotherapy that has been used in India, and they had good experience and outcomes with it. And so we opted for this high dose of same agents that we use for intraocular, but in much higher doses and for longer, for 10 cycles. And the plan there really is to give them chemo till you can safely do an enucleation. You don't want to exenterate these kids. So we do give 2 cycles, do an MRI. Enucleation is possible, you go for enucleation. If not, give another 2 cycles and shrink the disease more till you can do a safe enucleation. But again, the important thing there is, as soon as enucleation is done, these kids should also be referred to radiation oncology, and they should really be referred upfront, because we know we have long lag times in scheduling. So we send these patients on day 1 to see the radiation oncologist, so that they've had their initial appointment and the scheduling for about 3 months from that time, when they would have done their first couple of cycles of chemo, had their surgery, and then they will go and get their radiation regardless of what the histopath shows. And at times you get complete necrosis in these eyes, and you really don't want to radiate them, but you have to, because we know the recurrence is high if they're not given radiation. This is in case someone was not able to download the protocol, you can try again. This again includes the pathology, radiology, radiation oncology, enucleation guidelines that you can refer to at your centers. Okay, so just very briefly, a little bit of update on where the study is right now. So we did the NBC submission in April. It was approved in June. So essentially, the study has been active since June 2022. Obviously, individual institutions have gotten IRB at different times, and as more institutions entered, the entry has gone up. And as of since October, we've been doing data entry in REDCap. These are the centers from most of Pakistan that are participating. So we have centers from Lahore, Karachi, Islamabad, and Multan. And actually, Faisalabad also has IRB now. We don't have any cases from Faisalabad as yet, but they have also gotten IRB approval. So we hope Faisalabad will be part of the team as well. Balochistan is a big vacuum here, which all of us in pediatric oncology really should not be there, but we don't have any center from Balochistan. I hope the Indus Center there can at some point join in. And KPK, again, we don't actually have a center participating. Dr. Tahir is here, so I hope we will have someone who will join our protocol from. And actually, all SKM Peshawar patients are also getting enrolled because they initially come to Lahore and the treatment is then completed in Peshawar. So we do have representation from KPK, from SKM Peshawar. So all 4 provinces, well, not all 4, at least 3 provinces are represented in. So enrollment so far, so this is REDCap, which is we have 116 patients enrolled over the last 1 year or so. And it's actually higher than this. So we're close to 158 to 60 because a lot of people have not entered the data into REDCap as yet. And once we have our data managers, that will start happening much faster, inshallah. And this is just a breakdown of where the patients are being enrolled from. So this is SKM Lahore and Peshawar is about 72, then Indus has 19 and so forth. And AKU needs to get a RB case, Dr. Zara. Okay, time. I'm kidding. Okay. All right. I've been telling my time is always gone, so I'll fast forward. So this is the forecast table. Our enrollment has gone up with time, and I hope that we are supposed to run this for 2 years. So by 2024, we should have at least 300 patients, I hope, enrolled and have some good data to talk about. This is just our initial demographic data. Average age is 3.4, which is expected. We know we have very late presentations. Duration of symptoms is 5 months, plus or minus 6 months. This is duration of symptoms before being seen by the oncologist. So this is a long time for retinoblastoma, up to a year. Most common presenting symptoms still is white reflex, but a lot of people presented with eye swelling, loss of vision, so advanced disease, eye redness. 40% of cases, so this 119 includes bilateral. So 40% of them were bilateral. And the gender male to female is almost equal, a little bit more of males, but mostly equal. The treatment assignment so far, 14% of our cases are bilateral of what we've enrolled so far. About 20% are on the extraocular protocol, which is a lot of patients actually with extraocular disease. And 66% are enrolled on the intraocular protocol right now. In terms of the group of the intraocular disease, almost half are DNE. So these are ones that unfortunately need to be included upfront, maybe not happening, but again, very high advanced stage disease, even in the intraocular. Again, I think as expected. So really the conclusion is that we need national multi-institutional studies to improve the outcome for these children with RB. All of us have been treating these for years on exactly the same protocols, but we need to know what's going right and what's going wrong and get better at it. Our initial data confirms that there's a delay in diagnosis and there is advanced disease, and further follow-up of these patients is needed to really assess survival. And we need participation from all teams involved to improve the care and outcome for RB in Pakistan. I'll just end with some pictures of my patients that have prosthetic eyes, all enucleated. So this is a good slide to show patients when you're counseling. And thank you everyone for participating. This is just an information form for people because we have a WhatsApp group for RB, clinicians, physicians, psychologists, whoever's involved in RB. And I think a lot of people in this room may be in that group, but if you're not, if you can just scan that and share your WhatsApp number, we can add you to the group, or there's a form at the back somewhere that you can leave your WhatsApp number on, and we'll add you to the group. So whenever something new happens, or if there's any questions, people will, post clinical queries as well. You can be part of that group. Thank you very much. Did I go fast enough to finish on that?
Thank you, Dr. Halima, Chandata, and our respected panelists. With this, we end our session with the shared hope of a healthier future for retinoblastoma patients in Pakistan. Now there is a short coffee break, and we will rejoin at 11:50 a.m. sharp. Thank you.